Yeah, thank you. So good morning, everybody. It's a real pleasure to have you all again after the Memorial Day weekend, and good afternoon to those joining from far away. It's such a pleasure to have Rasha Lamy join us today. We have a long history, me and Rasha. We worked together in Milano for a year, which was a memorable year in which Russia published an incredible amount. And I think all of us, me and Antonio, both knew she was destined for great things afterwards, which she has done. And I think has published one of the most important studies in the last few years. If anything, it's forced us all to think a little bit more when we see patients and treat our patients. And it's challenged a lot of our beliefs. So I can't wait to hear what you're going to tell us about now and challenge us more. And I'm hoping you're going to give us a taste of what Orbita-2 is going to be about too. So, Rasha, it's all yours. Thank you so much.
Thank you very much, Azim. It's a super pleasure to be here today, particularly because Azim taught me so much in my year in Milan and actually continues to teach me stuff. And it's just fabulous to work with, a very, very old friend. And I am very happy at any point to take any number of questions. I'm here today to talk about revascularization in stable coronary artery disease, a little bit about where we are in terms of the data, and also importantly, what's coming next. Obviously, when I speak to what's coming next, my particular interest is in the studies that we're doing, and I'd like to tell you a little bit about those. So here are my disclosures. So let's think about stable coronary artery disease. So we have patients who come to our clinic all the time, describing sometimes very typical classic chest pain on exertion, other times breathlessness or more atypical symptoms. But we take them to a cath lab and we perform an angiogram and we see a stenosis like this. And we then have the question of how should we approach the stenosis? And I think this is where things have changed. And I think decades ago, the only treatment of choice would have been to try and stent this lesion or balloon angioplasty this lesion in the early eras. But over time, we've started to realize that there's much more that we need to learn. And as simplistic as it might be to imagine we can just open up a blockage and all of their symptoms disappear, we've seen over time that this is maybe not the case. So let's think about why we thought it was reasonable to stent these patients. Well, for decades, we've all been taught that ischemia is incredibly important to patients and is something that we need to try and treat. What I think we haven't been so good about is thinking about what causes ischemia beyond just the epicardial stenosis that we see in a cath lab. And what we all know and what we were taught in medical school is ischemia can be caused by lots of things. So, of course, it's a reduction in the blood supply to the heart or a mismatch between the supply of blood supply to the heart and of the myocardial muscle. And this could be caused by an epicardial stenosis like we saw, an occlusive coronary artery disease, or perhaps by issues with microcirculation, sometimes even problems with spasm or problems with structure of the cardiac muscle. There are lots and lots of different things that can impact on the blood supply to the heart. Over the years, we've made many assumptions about ischemia, and this is what I think I'd like to challenge and maybe discuss in our discussion later. The first is that when we see a reduction in blood supply to the heart, it must be linearly associated with angina. So the worse the ischemia, the more likely it is that our patients might have chest pain. We also assume a linear association with poor outcomes. So again, the higher the burden of ischemia, the more likely it is that our patient will do worse. We also presume that we can improve this ischemia by revascularization, whether it be with PCI or with CABG, and that we can use binary cut points to try and work out whether or not we should consider revascularization in a patient. So you might use an FFR cut point of 0.80, an IFR of 0.89, maybe even MRI cut points of ischemia. But we use these binary cut points as if ischemia is a dichotomous variable. And then finally, we assume that if we improve ischemia with revascularization, everything else will improve. The angina, the poor outcomes, everything gets better if we improve the blood supply to the heart. Now, before we start going through some of the data, I'd like you to ask yourself some questions and think about this field a bit more globally. So firstly, is there a rush to revascularize what we see? Must we, as soon as we can, get these patients to a cath lab and stent their lesions? Secondly, is there any harm of a trial of anti-anginal therapy, and how much do you approach anti-anginal therapy with your patients? Finally, what do you expect to tell your patients to expect from revascularization? How much do you counsel them? And then, do you see revascularization as being universally effective and without any risk? Or could it be that you've seen patients in your clinics for whom you've performed a perfect angioplasty and for whom there's really no change in their outcomes? So let's think about some of those assumptions that we've made. So ischemia really is associated with worse outcomes, and we've definitely seen that from observational data. What we've seen is that if we take patients who have positive stress CMRs, they're much likely to have higher rates of cardiovascular death, non-fatal MI, than those patients who do not have ischemia on a stress CMR. Now, the question is, why is this? It might be because they have ischemia on their stress CMR. It may also be because in observational data sets, these are patients who are sicker, who have lots of comorbidity, and sometimes patients who are unsuitable for revascularization, and therefore remain with a very high ischemic burden that then triggers events in the long term. What we've seen more recently from the ischemia trial is, while we thought that a reduction in blood supply to the heart and high levels of ischemia, in this case moderate or severe ischemia in stable patients, we thought that that must trigger revascularization, and that by improving ischemia in these patients, we could improve outcomes. We found that the data was very different. So what they did in ischemia was take stable patients with high burdens of ischemia. Those patients had a blinded CT coronary angiogram, and if they had left main disease or unobstructed coronary arteries, they were excluded from the trial. If, however, the core lab felt that the CT meant that they had coronary anatomy that was eligible for re-randomization, they were randomized to have either an invasive strategy with an angiogram and revascularization as necessary, or a conservative strategy with no angiogram and just medical therapy. And what did they find? Well, they found no difference in cardiovascular death or MI between the conservative or invasive arms. Now, this was at a median follow-up of 3.2 years. And you might say, well, we see that the arms cross and maybe things might change over the long term. There's been many discussions about myocardial infarction rates with a finding that the overall myocardial infarction rates were similar between the two arms, but that procedural MIs were higher in the invasive strategy arm and spontaneous MIs were higher in the conservative strategy arm. Now, again, we don't know what that means for our patients in the long term, but we are waiting for ischemia extend, which will give us much more data in the long term on what happens next. However, what we have seen is that the high burden of ischemia and revascularizing those patients doesn't seem to make a difference in terms of their outcomes. Now, interestingly, we saw some other very important data from ischemia. There appeared in this trial to be no association between the burden of ischemia and overall outcomes. So while in the observational data sets, high burdens of ischemia predict outcomes, in the randomized control trial, this didn't seem to be the case. And you might question why that is. Well, maybe because ischemia in of itself is not the thing we need to worry about. It's actually just a surrogate for plaque burden. And when it forms a good surrogate for plaque burden, as we've seen in lots of those observational data sets, it can predict events. This is data from Scott Hart, which was a CT-based study in which patients were randomized to have standard of care to diagnose their chest pain and direct their treatment versus a CT coronary angiogram. And what they found was just randomizing patients to a CT strategy seemed to reduce death and MI. And you might say, well, why is that? Well, actually, it seemed to be potentially because patients in the CT arm were diagnosed then with and told what levels of atherosclerotic burden they had and treated potentially with the right risk prevention to try and reduce events in the long term. We've seen some of this data from Prospect 2, which also found that plaque burden was really the predictor of events in patients who had intravascular imaging to try and work out how much plaque burden there was in their overall coronary tree. And what we know importantly is it's the total burden of plaque that predicts events in the long term. So it's not so much those severe lesions that we see on an angiogram that need to be stented or bypassed immediately. It's actually the overall plaque burden for a patient that seems to predict their events in the long term. And we've seen this from ischemia. So in ischemia, on the CT scans, what they did was go back and look at plaque burden. And while ischemia and the reduction in blood supply to the heart was not associated with long-term outcomes, plaque burden was. And so if you had more atheromatous disease on your CT, you're much more likely to have poor outcomes, with mortality events being much higher in those patients with the highest Duke scores on CT. So what does this all point to? Well, it all points to the fact that actually, if we really want to get events down in these patients, it's probably not to stent every lesion that we see, but it's actually to think about their risk in the overall. And if we give them the right medical therapy, that actually prevents events. And we know this. We know that aspirin and antiplatelet therapy in secondary prevention reduces events. We know that lipid lowering is incredibly important. And that is because these medications act on the whole coronary tree, not just on the lesions that we see in an angiogram and that we feel we need to treat. What's also important is that we might believe that revascularization is really important in terms of reducing angina, but actually the observational data out there shows us that without revascularization, angina reduces over time. Now, that is a bit counterintuitive, and we might wonder why that is. It's probably for a variety of factors. One might be that the patients actually stop doing the thing that caused angina. It might also be because ischemia is good for the heart and it preconditions us to moments where the demand on the heart outstrips the supply. And it might also be because we develop collaterals to areas that have stenosed over time, and that those collaterals backfill the blood supply to that area of myocardium, and the angina gets better. So importantly, what we need to remember is even if angina persists, revascularization always remains an option. So it's not something that you've taken away from your patients. Now, of course, you might say, well, the lesion might get worse and perhaps it'll be harder to treat. But in general, the option of revascularization always remains. So let's think back to those original questions that I asked. So I would argue that there's no need to rush to revascularization in chronic coronary syndrome patients or stable coronary artery disease patients. Now, of course, there are some caveats to this. There are some major exceptions to the clinical trials, which excluded left main disease and in the main excluded severe 3-vessel coronary artery disease. They also excluded severe LV impairment. So in those patients, you might still consider we don't really have the data and that you want to opt for revascularization up front. It's also important to remember that most of these trials only had medium-term follow-up. So the longest follow-up we have from ischemia is a median of 3.2 years. And for many of us, we'd want to see much longer follow-up before we're happy that we definitely don't need to worry about our younger patients. So now let's think about how we treat those patients as we're waiting to potentially revascularize them. So I think it's really important to treat symptoms. And of course, for most patients with stable angina, what we usually do is give them lifestyle advice. We give them secondary prevention, which, as I've said, is very important to reducing their risk. And then we might start introducing anti-anginal agents with a first line medical agents such as a beta blocker or calcium channel antagonist, seeing them again and giving them a second line if necessary. And the guidelines would say only then should we consider revascularization if they have persistent stable angina. Now, we've had these guidelines for a long time, and we still know that we're not very good at doing this. And sometimes it's because our healthcare systems don't really allow us to keep seeing patients and keep introducing more agents. But sometimes it's also because we rush to revascularization at a much earlier stage. So how do you make the choice of which anti-anginal therapy to use? Well, the guidelines would tell us that up front, we usually use a beta blocker or a calcium channel antagonist. I usually use some other metrics to work out which of those two to use. So if, for example, a patient's had previous MI or heart failure, I'm going to opt for the beta blocker up front because it has additional benefits. If, however, a patient's had uncontrolled hypertension or vasospasm, I'm going to go for the calcium channel antagonist up front because, again, I know that it has additional benefits. If they continue to have persistent angina and I've tried beta blockers and calcium channel antagonists, I might think about some extra agents. And so here again, I think about the whole patient. And if they've got problems with hypotension or bradycardia, I might think about an agent like ranolazine. Otherwise, there are lots of other agents out there that we can consider. However, there are lots and lots of issues with anti-anginal agents, and we know these from our clinics all the time. This process of introducing lots of anti-anginal agents takes time and effort, and we need to prepare our patients for this. They can have possible side effects, and again, it's important to talk about this with the patients. Some of these anti-anginal agents really don't work very well for some of our patients. And of course, there are issues with adherence and persistence, and you might think, well, how long can patients tolerate high burdens of anti-anginal therapies? Also, for our patients, there's often a preference for revascularization. They don't want medication. They want to be able to stop some of their medications and have a stent instead. And then, of course, we can't get away from the fact that for some of us and some of our healthcare systems, there is a push to do procedures with more reimbursement, knowing that actually that's important for the healthcare system too. So how about whether it's possible to achieve optimal anti-anginal therapy? Well, from the Orbita trial, we saw that albeit in a short period, within 12 weeks, patients really tolerated high levels of anti-anginal agents. And on average, we were able to get patients onto 3 anti-anginals, and they were able to tolerate that for the maximum period of the trial. The question might be, what happens in the long term? And do they really tolerate this if you leave them on 3 anti-anginal agents for years and years to come? I would argue that there is really minimal harm of an initial trial of anti-anginal therapy. You've got time, you can do it, and that you should allow time for this. So there is caveats. It can take up to 3 months, I would say, to get patients on the right anti-anginal therapy. You need to be able to follow them up and introduce and up-titrate these agents. And you've got to counsel them to the fact that this isn't a quick fix and it's going to take time to get there. Now, let's think about how we counsel patients. So often our patients will say to us, I want revascularization, or I want a stent. And that's often, unfortunately, because their preference is based on very outdated beliefs. Many, many patients still believe that stenting improves their long-term prognosis and prevents myocardial infarction. That's very different to the referring cardiologists and the interventional cardiologists, who for a long time have understood that the main reason to stent patients is symptom relief. And so if you are going to have a conversation with patients about what next, you've got to also challenge some of their outdated beliefs and educate them as to the role of stenting or CABG in their condition. The other thing that's important to tell patients is that even if you have very successful revascularization, many, many patients still have symptoms. In the Orbita trial, we saw that up to 50% of patients still had chest pain despite very successful revascularization. And all of the data out there from various trials and registries shows that 30 to 60% of patients will still have chest pain despite very adequate revascularization. So you have to tell them that this is not all going to necessarily get better just because you perform angioplasty. There is a proportion of patients who still come back. So in counseling patients, it's really important to educate patients. And I think it's really important to involve patients in shared decision-making before undertaking a procedure that has some risk. So of course, there are caveats again, that can take time and it's not the preference of all of our patients, but I think it's something we have to do, particularly because the data on a lot of these, on this therapy is really awaited. Now, are there patients where ischemia, where PCI can improve symptoms? Well, it's difficult to know at the moment, but what we have seen from the Orbita data is that if in patients who have the highest burdens of ischemia, so this is based on FR and IFR, you can predict the amount of ischemia improvement you'll get with PCI. So when you angioplasty these patients with the highest burdens of ischemia on invasive physiology, you will also expect the greatest reduction in stress echo ischemia. Importantly, what we haven't seen is that prediction with symptoms with invasive physiology. But what we have seen is that with high burdens of ischemia on stress echo, we do seem to see some angina improvement. So while the headline figure from Orbita was that angina didn't really seem to improve with PCI compared to a placebo procedure, there are some patients where PCI seems to make a difference. And it's probably those patients with the highest ischemia burden. And so for some of your patients, you might be able to expect some symptom relief. Importantly, we also know that if we're taking patients to the cath lab, we need to be able to use tools such as physiology and intravascular imaging to try and get the best outcomes. And I think it's really important to use these tools, because if we still don't know exactly whether what we're doing really makes a difference, we've got to make sure that we do it well. So if a choice is made to intervene, then I still use intravascular imaging, invasive physiology. I try and get the best results. Again, this can take time and it requires training. So by the time you get to the cath lab and you decide that you are going to intervene, you've got to make sure that you do it properly. So let's now look at a case example of just the way in which I treat some of my patients these days. So this is a 62-year-old male. He was seen in rapid access chest pain clinic. He'd had a 3-month history of exertional chest pain. Importantly, I always perform an ECG and an echo because I'm looking for any signs of instability, and they were both normal. He then had a CT coronary angiogram because actually in our system in the UK, most patients are filtered to a CT coronary angiogram first, and his CT showed extensive calcification. And because of that extensive calcification, they were not able to visualize the coronary anatomy beyond giving us a calcium score. So what next? Well, I decided at this point to refer him for a diagnostic angiogram. And this is key for me in terms of making a diagnosis. But as you might see, I didn't plan to intervene at the time of the angiogram. I just wanted to perform an angiogram and see what was there. And you can see what we found on the angiogram, a very tight proximal LAD stenosis. Now, you might argue we shouldn't get this patient off the table. We must stent this patient immediately because he has high risk. But this patient came to our cath lab following the results of Orbita and ischemia. And at that point, I remain still quite happy that these patients can still have, for them, the most important thing is risk prevention, and we can still take our time. So this was in February 2020. So I had a discussion with the patient. I started him on aspirin, bisoprolol. He was on pravastatin, so I changed him to atorvastatin. And the plan was to see what happened next and then plan angioplasty only if it was necessary. So I saw him again in June 2020, and he said, my pain's gone away. And as you can imagine, between February and June 2020, it was obviously the pandemic, and all of our elective procedures had been stopped. So there was no option at this point to perform angioplasty, but the patient also felt asymptomatic. So we chose to continue with the no revascularization approach, continue follow-up and see how he did in the long term. I planned to see him much earlier, within a few months, but unfortunately, again, because of the pandemic, he wasn't seen for a year. And a year later, he told me actually he'd had quite a turbulent year. He'd had recurrent chest pain and breathlessness. He'd been starting on another anti-anginal agent by his GP, but he remained symptomatic. Now, of course, at this stage, I was worried. I thought it's potential that proximal LAD lesion has deteriorated and maybe he's even had an event. So I performed an ECG and an echo, and luckily they were unchanged. And at this stage, I said, well, you're now on 2 anti-anginal agents. You've had some time of thinking about things. Of course, I could up titrate anti-anginals further, but at this stage, I think it's reasonable to consider PCI. And he was very keen to think about another approach. So together we chose PCI, and he went on to have an angiogram, and you can see the angiogram pictures here. And I was worried, of course, that this LAD lesion may have deteriorated, but in fact, it looked really very much the same. And I was happy at that procedure to perform angioplasty and, of course, optimized it with intravascular imaging and got a very good result. And as you can see, it took me 18 months essentially to get to the point of angioplasty with this patient. And in that time, there was quite a bit of counseling and quite a bit of up titration and medical therapy to get him there. So what do I think about the future? So I think there are lots and lots of questions that still remain. And I'm just going to pose a few of those questions now. Of course, there are lots more. One is, are there any anatomic subsets for which revascularization is prognostic? So should we treat our left main lesions differently? Is it possible that proximal LAD disease is prognostic? We didn't see that from the ischemia data, but people out there would still say there are some proximal LADs for whom they feel revascularization is still important. The question is, will we ever get data that really tells us the answer to this question and tells us whether there's some patients for whom we need to upfront think about revascularization? The next question, and I think this is going to be a really important question in the next decade, is which plaque characteristics really predict risk, and can we use our intravascular imaging tools or our CT tools to look for particular characteristics that predict the vulnerability of plaque? And are any of these characteristics things that we could modify by revascularization, or is all we need to do is the only thing that we need to do give these patients really high levels of risk prevention medication? And I think this is going to be a question that we're going to hear more and more on over the next few years. And hopefully we'll get to a point where we understand why some people have very mild atheromatous disease and then suddenly have a myocardial infarction, and others have very, very severe angiographic disease and never have a myocardial infarction. And what is it about plaque that changes their outcomes? I think it's going to be also really important to work out where PCI is most likely to be effective for symptom relief. Which patients should we target with PCI? And as I said, from some of the Orbita data, we've got some signal now that there's some patients for whom symptom relief is really important, others not so much. And then finally, are there some alternative treatments for stable angina? And are there other things that we can do beyond revascularizing those patients? So I'm going to just look at a few of the trials that we're doing and tell you a little bit about them. So I guess the most important one of the trials that we're doing, and hopefully you will hear about next year or the year after at the latest, is Orbita-2. So Orbita-2 differs from Orbita-1 in a number of ways, but in the main asks exactly the same question as Orbita-1. Does angioplasty improve symptoms by more than a placebo procedure? And we're taking patients with angina or angina equivalent symptoms, the kind of people you see in your clinics all the time. They have to have evidence of ischemia pre-randomization. And this time they can have both single vessel coronary artery disease or multi-vessel coronary artery disease. And they are recruited via either a coronary angiogram pathway, the invasive pathway, or a CT coronary angiogram pathway. These patients are admitted, they have an enrollment visit, and this is kind of key. We stop their anti-anginal medication. So unlike Orbita-1, we're asking a question that is much more simple. Does angioplasty improve angina when compared to a placebo procedure in patients who have no anti-anginal therapy? So we are asking for the true benefit of angioplasty, not a benefit that might be attenuated with patients already treated with anti-anginals like we did in Orbita-1. They go into a symptom assessment phase, and here they have their daily angina frequency documented, and it's actually documented on an app. And every single day, they fill in their symptoms on this smartphone app. They then come in for a pre-randomization visit where we do lots of different questionnaires and an exercise tolerance test and a stress echo. And then they come in for the randomization visit where we do the research angiogram. And just like Orbita-1, they're listening to music via headphones. They have invasive physiology, but this time the operator can actually see that physiology and decide whether anything else is necessary. And then they have at this point, if they've had any evidence of ischemia on a pre-randomization or a test, then they can be randomized to PCI or placebo, but only once they have been sedated to a deep level of conscious sedation, just like Orbita-1. The patients are randomized, they have no idea what they've had done. They come out of the cath lab and none of their caregivers know what they've had done. They enter the follow-up assessment phase where, again, every single day their angina frequency is documented on a smartphone app. And this is done for 12 weeks, so it's a much longer time period than Orbita-1. They then finally come up for their follow-up visit where they have questionnaires, an exercise test, and a stress echo again. Now, will we be able to answer the question of does angioplasty improve angina more than a placebo procedure? I hope. But of course, there will be all sorts of criticisms for this trial on lots of levels, I imagine. I hope that people will start to understand that in this trial, what we try to do is make it as inclusive as possible, and also think about that pure question of whether we can expect symptom relief with angioplasty. Now, we've developed some other trials where we're trying to look at more than just what is the efficacy of angioplasty, but also which patients can we select to have angioplasty, and how do we work out which patients will have the greatest benefit. And the first of those trials is the Orbita-Star trial. So this is a trial where we thought we really need to think about the types of chest pain that patients report. And we felt that we couldn't assume that all chest pain reported by a patient with a severe lesion was angina. Just because they have a severe lesion or they have evidence of ischemia, we can't presume that that chest pain must be caused by the stenosis. And perhaps the problem of why PCI doesn't work in some patients is because we're not really accurately selecting which patients are truly symptomatic from their lesion and for whom we should target our PCI. So it was based on that premise that we've all seen in the cath lab, where we see a really tight lesion, and here's a right coronary artery lesion, and we start performing angioplasty. And then when we're performing angioplasty, the patients who are blowing up the balloon say, I've got lots of pain. And we are often very happy to hear this. We kind of go, brilliant. Is that pain the kind of angina you normally get? And if they say, yes, that's my angina, we're very pleased. We think, okay, well, if that's your angina, then we're highly likely to make it better with this stent. But sometimes we get patients say, well, I've never had this sensation before. You know, they say, I've got chest pain. You say, is that what you get at home? And they say, no, I've never had this before. And our question was, are those the patients for whom our PCI isn't really effective? Because whatever their chest pain is, it's not really caused by the stenosis. So this is a really interesting study. It's a study in which we do all sorts of steps, but the most important steps for you to think about are invasive protocol. These are patients who have single vessel coronary artery disease who are due to have a stent put in, but before we put the stent in, we do lots and lots of balloon occlusion testing versus placebo occlusion. And we're trying to work out in these pairs of balloon versus placebo occlusion, whether the pain that we trigger in the cath lab is anything like the pain that patients get at home. So we ask them to essentially score it in terms of similarity with the pain that they normally get. And that's going to be a very interesting study, because perhaps it's those patients who have really similar pain in the cath lab that we can induce, who have the greatest bang for their buck when we stent them. And there's lots more that goes into this study, but we're going to hopefully be reporting this next year. And the next study that I guess is really important to tell you about is that question of, are there other therapies that we can use to treat angina? And this is a study that looks at a particular therapy, which is the coronary sinus reducer. And I'm not sure if you guys use this in Monty Hart. It's certainly something that in the UK is used only in a small proportion of centres. So interestingly, this device that narrows the coronary sinus was first tested in a placebo-controlled trial that was published in 2015 and is said to have efficacy of benefit in terms of reduction of angina in patients who have refractory angina, so they have no options for revascularization. However, the rollout across the world really hasn't been great. And I know that in the US, there's obviously the Coronary 2 trial in which the investigators are hoping to see a placebo-controlled benefit with the coronary sinus reducer. So the trial is essentially being repeated out in the US. But despite some evidence of angina improvement with this device, the rollout hasn't been as expected. And we wondered why that was. And we thought, well, maybe it's because none of us really understand the mechanism of action of this device. It's purported to redistribute myocardial blood flow across the heart and perhaps to reduce microvascular resistance, but we're not sure if that's how it works. And certainly there isn't a lot of evidence out there that really tells us that that's what it does. And importantly, we wanted to see whether it truly has a placebo-controlled efficacy on angina, because there are question marks about the degree of placebo control that was instituted in that first Coronary trial. So what we've done here is design the Orbita-Cosmic trial, where we take patients who have stable coronary artery disease and refractory angina, no options for treatment. They have ischemia on a stress CMR, and they have to be on maximum tolerated medical therapy. And these patients are enrolled, have a series of questionnaires, and then they have lots and lots of physiology metrics taken in the cath lab. Importantly, they have an MRI before randomization at enrollment, and they have another stress MRI at follow-up. And they are randomized to have either the coronary sinus reducer or a placebo procedure in the lab, in much the same way as we do with Orbita. They're listening to headphones, they're listening to music, They are sedated to a deep level of conscious sedation, and then they're randomized to one of these treatments. And then they come back for follow-up assessment. And throughout the period of being part of the trial, they are monitoring their angina on that smartphone app, which we're increasingly using in lots of our studies. And the question is, does the coronary sinus reducer really change their myocardial perfusion? And does it really change their angina? And it will be very interesting to see what the results are of this trial, which we hope to report in the next couple of years. So in summary, I think that in patients with stable coronary artery disease, there isn't really one strategy that fits all of our patients. And importantly, I think we really can take our time in trying to work out which strategy is best. I do think that a trial of anti-anginal therapy is currently a very good option, gives us lots of time to evaluate the symptoms, and obviously we can always offer revascularization once we've tried anti-anginal therapy for those patients that we think are most likely to benefit. I think it's probably likely that plaque burden is much more important than ischemia, and we're going to learn much more about this in the coming years. Don't ever forget that revascularization is always out there and an option for most of your patients, but it just doesn't necessarily need to be the first choice. You've got to involve your patients in shared decision-making, even though that takes time, because it's potential that you're going to do a procedure that has long-term risks. And so in order to ensure that we improve long-term outcomes, we need to select it for the right patients and make sure that our patients are well counseled as to what to expect from the procedure. And then finally, we've got lots more to learn. And I hope that I've shown you some of our studies, but there are lots and lots of other studies out there that will inform us in the next decade. And while we thought the stable angina was simple and we'd fixed it and we understood exactly what to do, I think we've actually learned that there's much, much more that we need to study. And I'll stop there.
Rasha, thank you so much. I've heard you talk before, and I think it's fantastic watching how much you've grown and seeing how well structured this talk is, and how you force us all to really question some of our norms and some of what we do every day, particularly around chronic coronary syndromes. I'm sure there's lots of questions. So the way we do this is, it's not about me asking you questions. Actually, you do this for the fellows. So it's all about them answering their questions. And I'm sure they have tons of questions to ask you. So I'm going to pass you on to the fellows. And I'm just going to go according to my screen here and who I see. So Andrea Scotti, go ahead.
Hi. Thank you for thank you for your talk. I just wanted to ask you regarding the patient you showed before. Why not performing an invasive physiology at the first time and stenting? Probably that's what most of us would have done.
Yeah, so that's a very interesting question, because actually we've got another study that I wasn't quite ready to show you yet because we're still waiting for ethics. But I would argue that FFR and IFR we've never actually tested them based on angina relief. We don't actually have any idea what the cut point might be for symptom relief in these patients. And while I didn't present the data today because it often gets lots of people upset, I would actually argue that for prognostic benefit, we actually don't know that IFR and FFR make a difference. What we know from FAME2 is that all of the prognostic signal was based on urgent revascularization. So FFR and IFR we've never had any proof that in revascularizing patients with low FFR or low IFR changes death or MI rates in the long term. What we have seen is that they're more likely to come back with more symptoms and we're more likely to stent them. However, in unblinded trials, that's often triggered by the fact that when they leave the lab in an unblinded trial, we say to them, oh, you've got quite a tight stenosis there. I haven't treated it today. If you have symptoms, please call me. And then they come back and they tell us they have symptoms and we stent them straight away. What we certainly don't know, if we now believe that revascularization is predominantly for symptom relief, which I really do believe now, we don't know what the cut point is for symptom relief. So I don't think that a cut point of 0.80 or 0.89 has ever been proven to be the cut point that causes angina or that should trigger stenting. It's probably likely that the cut point is much lower. And more importantly, it's probably likely it's different in different patients and maybe different in different patients on different days. So we've got a study called Orbita-Star, which actually next time you invite me, Azim, I will present. but we're just waiting for the ethics of that, which is why I haven't kind of presented the protocol to you today, because it's still in modification. But it's basically an in-cath lab study where we're trying to work out at what point does your stenosis cause pain, and at what level of IFR or FFR could you predict that if I stent this lesion, they might get better. So while, yes, I think that approach of using invasive physiology it would be used in lots of centers, I'd probably argue that most centers wouldn't put a wire down that lesion. They just say it's tight and I need to just stent it. And if you wanted to give yourself more reassurance, you could put a pressure wire down. But I'd actually argue that there isn't any data out there that tells us that that changes outcomes.
Okay, great. Thank you. Sebastian?
Thank you, Azim, and thank you very much for this really superb presentation. It was a pleasure to listen to you. I've got a question. You talked about the Scotthard data and the CT sub-analysis from ischemia, and showed the importance of plaque burden. Given the somehow increasing importance of coronary artery calcium for the prediction of adverse events, what's your personal opinion on the future role of maybe CT or coronary artery CT scan for prevention? Even which patients do we offer this? Can we offer this in the future? Also, cost effectiveness question, maybe, or reimbursement question. What's your opinion on this?
So I think that's a brilliant question. So obviously at the moment we don't have the data that doing a CT or knowing a calcium score and changing our primary prevention approach on patients changes their outcomes. But I really do think there's going to be a big space, and I think we're all going to see this in the next few years, of CTs as a mechanism of predicting risk. So not just giving us calcium burden, but telling us when they see napkin rings or various high-risk features, what we should do next. And the studies that will come out next, I'm sure, will be, can we use our CT to decide whether it's time to institute PCSK9 inhibitors, or whether it's time to really change our risk prevention approach for these patients. I think that that is going to be the future, actually. And in the UK, that's very much becoming our pattern of our direction of travel, because our CT is now the first line for the vast majority of patients with stable disease. The problem will be, I think, that at the moment, our only reason to revascularize patients predominantly is symptom relief. So really should probably be triggering that CT in a patient with symptoms. The question that we've never had answered is, what about the general population? Does it make any difference if we CT out asymptomatic patients? And I think to power that study and ever make a difference in outcomes, it'll be impossible to do, I would imagine. And obviously what we know already from the CT screening studies is that if you screen patients who are asymptomatic, it doesn't make any difference what you do in terms of their CT. We may never get that data. But what might be really interesting is all of this data on high-risk features. And, is there a role for revascularization in patients with high-risk features? I don't know. But I think, we all see this. Our STEMI patients that come in very rarely tell us that they've had 3 to 6 months of worsening angina and they're under a cardiologist and now they've had their MI. They're often de novo presentations. And meanwhile, our patients who develop CTOs don't usually tell us, sometimes they do, they don't normally tell us about a particular moment where they didn't present to a clinician and they were clearly having an MI and they missed it. Sometimes they do, but it's rare. So there's something quite different happening in these patients, I think. And the approach that we had to just stent them all probably is wrong. There's just different pathologies, I think, that some of these patients are more likely to have a propensity to have MI and some aren't, and we don't quite know why.
Yeah, it's pretty interesting, Rasha. We've got all these amazing studies, all these technologies, yet we understand still so little about progression of disease, right? And how patients arrive to having, their first presentation with 2 CTOs. There's so much we have to learn.
Yeah, we don't at all get it. And it can't be that stable disease is stable in everyone. We all know that. Mm-hmm. There's certainly some patients who suddenly have instability because we see them all the time, but we still don't know how to predict it. And that's very odd, isn't it, after all this time?
Absolutely. So I'm going to go to Jesse next, but I just want to remind the fellows and everybody else who's joining, if you have a question, either raise your hand We can allow you to speak or type it into the chat or QA. Thank you. Jesse.
Thank you for sorry, got some echo. Thank you for a great talk. Very hypothesis generating, especially when you bring up the ischemia trial to a bunch of interventional cardiologists. I think there's two things that your talk made me think about. It's one, what we do before the patient gets to the lab, and the other is what we do once we get those referrals and the patient's in the lab. If you think about the ischemia trial, the interesting thing is a lot of those patients never even ended up in the lab. And the case that you brought up, or half those patients, and the case that you brought up with this patient with this proximal, very, very tight LAD, scary looking lesion is, why bring this patient to the lab in the first place if you're going to refer to ischemia? And so one thing that I think about is, what makes you make a decision to even do a diagnostic cath in stable angina? And the other thing I wanted to kind of comment on, because we're talking about kind of special procedures, FFR, or different things that we do in the cath lab, including induced ischemia. What about doing rehab for patients, cardio rehab before the case? When to use cardiac rehab? And should we be referring patients with stable angina to cardiac rehab before we even send them for diagnostic procedures?
Yes, I have to say, Jesse, both of those are fantastic questions, right? So I'm gonna kind of take the first one first. So I think you're absolutely right. There are lots of limitations with ischemia, and I deliberately in this talk didn't think that this was a moment to kind of go through that. I think despite the many limitations of ischemia, there is obviously a signal and a direction of travel from every trial that we've seen that the prognostic benefit of revascularization cannot be as great as we thought. Because if we think back to the original STEMI trials and kind of PAMI and the sequence of trials, they had lots of limitations, and there was all sorts of issues with inclusion criteria and all the rest of it. But despite that, primary angioplasty in STEMI patients has a very, very, very strong signal for benefit. So I'm an interventional cardiologist, and I have entered up in this world of kind of thinking a lot about what we do, desperately trying to prove that we do the right thing, but actually increasingly thinking, I don't know anymore. I know that for the acute patients, we know what we're doing. For the stable patients, I'm not so sure. However, I still think our patients want a diagnosis. And I think just saying to a patient, you've got a high calcium score, but I can't tell whether you have a left main lesion, I can't tell if you have severe three vessel disease, is kind of not enough. And so for me, it's still very important to do a test to look for high risk features, even though I don't know that they're high risk because we don't have any of that data. But importantly, to look for the coronary anatomies that were excluded from the trials. So that's one reason why I'm still doing diagnostic angiograms. The other reason I think is that patients want a diagnosis. So, you might come to that diagnosis with a stress test, you may come to it with a coronary anatomy test, but somehow you need to tell them what's going on. And then, but importantly, I think while that directs your treatment, it doesn't have to lead you straight to revascularization. And then on your second point on cardiac rehab, so there's a trial that we're looking at the moment. We're sort of, at the moment, it's maybe going to be called push through angina, but it's based on the premise of I don't know if your question was based on previous reading, but in peripheral vascular disease, there is a piece and quite a bit of data out there on if you make patients walk, their pain gets better, right? And they develop collaterals in their peripheral system, and they maybe get better. In the coronary space, that's never existed, probably because we do exactly the opposite. We say, oh, don't exercise too much. Let's wait and see what we find in the cath lab. But I think you're absolutely right that it may be that what we actually need to do is rehab these patients, see what happens to their pain, and then decide what to do next, if we're totally comfortable that they're going to remain stable. And so I think that's a very valid thing to think about in future trials. And as I said, we've been moderately looking at that in a trial that we're thinking about developing.
Great, thank you, Jesse. It's interesting. I just want to mention, Russia, that we in the US we have this national registry run by NCDR, okay, and one of the metrics that they give us quarterly is our appropriateness and how appropriate our revascularization is, okay, because there are these appropriate use criteria. So it's interesting that one of the most important appropriate use criteria where we fail, I will be very honest, as an institution, but I'm sure we're not the only institution, is the fact that you shouldn't be doing PCI in stable angina unless your patient's taking at least 2 anti-anginals. And it's something we fail on. And I think, it's something we're working really hard to be better, to make sure our patients have at least had a trial of 2 anti-anginals before coming to PCI. But it really fits in with everything you're saying today. Before we go to Bob, there was a question in the chat from Omar about the role of using OCT to decide about the need for revascularization, chronic coronary disease. I don't know if you want to make any comments.
Yeah, so again, a fantastic question. So, I guess we all hoped initially with either spiritual histology and then with the advent of OCT that we could use plaque characteristics on intravascular imaging to really guide, which patients we treat. What we've seen from the prospect data is, interestingly, there obviously is lots of OCT data that tells us that, there are some high risk features on OCT, whether it's thin cap fibroatheroma or any others, that seem to predict outcomes. But what we haven't seen is that fixing them with a stent makes any difference. And so that, I think, is the space that we'll be watching, right? And is that because the numbers you need in those trials are far too big and we can't see it in the sort of smaller trials that we're doing? Is it because that's not the right high risk feature to be looking for and there are other ones that we need to find? Is it because it's not just the presence of something like thin cap fibroatheroma that makes a difference, but then also an inflammatory process or something else on top that makes the lesion rupture? I don't know, but I think this is going to be where things go. I think it's going to be much less about, oh, it looks tight, let's stent it. It's going to be, okay, probably the fact that it's tight and has taken its time to become tight means it's probably much more stable. And those are those patients who will be ischemically preconditioned, who will have developed collaterals, whose plaque is much more stable. And it's the milder plaque that's the scary thing that we need to be thinking about.
Yeah, absolutely. Bob?
Yes, thank you so much for the talk. And it's very nice to see you from London. I'm going to go a little bit on a different direction, which I think is more multi-specialty driven. We do a lot of stress tests and we refer a lot of people for angiograms pre-surgery here. Knee replacements, kidney transplants, and, what I would consider low to intermediate risk surgeries. Some of these patients are completely asymptomatic. Some of them may have mild symptoms, what you would classify as stable angina. You find, especially in the renal patients, you stumble upon significant stenosis in a patient who is, you wouldn't say largely asymptomatic because they don't do much. How do you approach, especially with the other specialties in the UK and Imperial College, when you have these lesions? These are patients who are pre-surgical. They came to you, quote unquote, for revascularization. How do you approach this in these patients who you wouldn't otherwise treat before surgery?
So that's a brilliant question. And I wish we would one day get the answer. It's so difficult because we actually, so Devaca Pereira was actually putting in a large grant application, which I was part of, on a trial that was asking just that question. It's called pre-op. And the plan was to try and randomize patients to either having a conservative approach before surgery or not, and then trying to work out whether, any of this predicted risk. But unfortunately, it was incredibly hard to get funding for, and it hasn't got funding for, because surgeons said, well, there's no way I would do an operation like that. And the funders said, you're exposing people to potential risk. And so we can't ever get the data for that question unless people are prepared to at some point bite the bullet and do the right trial. the question on the renal space is also really interesting, because in our institution, it's just like you, we still do diagnostic angiograms, not even stress tests, but diagnostic angiograms on every single patient on the renal transplant list. Now, we've got the data from ischemia CKD that says that revascularization makes no difference in CKD patients. In fact, they are just very, very high risk patients overall. However, very few of the patients in ischemia CKD were renal transplant patients. They were probably super end stage renal patients who, you know, were kind of no hopers. And so we once again tried to have a think about a trial that was based on, you know, renal transplant patients and what's the right path. And we tried to power the trial, and basically it would take, because very few of them have events during the transplant or in the post-operative period. So when you power it for superiority, you need over 10,000 patients, and non-inferiority seems to make no difference. You know, what's the point in doing that trial? So I don't know if we'll ever have the answer, but that's somewhere where I'm sure we're not doing the right thing, and where we all do different things. In some places you do, you know, a stress test, and others you do an angiogram. What we deem to be a high risk operation is different in different countries. Some of us just do it because our local services demand it. And so that's a space that is wide open for research. And then the final thing, just to come to your point, is sometimes what I find is that interventional cardiologists have really been educated over the last decade. I think we all have, as to the fact that we need to think a bit more about what we do. And we know about, you know, in the US, the appropriate use criteria and other places, but our referring physicians have no idea. So if I give a talk about stable coronary artery disease to our primary care physicians, they genuinely get more cross than any interventional cardiologist. They say, why would you ever not fix that lesion? You know, and they don't even understand lesions in angiograms. So if we don't educate those people, then we won't really get any further. And then finally, you know, the real problem that we have is if our referrers don't really understand, and they refer to you, a patient, and then you decide not to stent them and just treat them conservatively. I'm sure it happens in the US, it happens in the UK all the time. The referrer then says, oh, I don't like that answer, I'll refer them to someone else. And someone else will just stent them, right? And it's a vicious cycle that just perpetuates myths, I think.
Yeah. The referrer problem is a big problem. Something we face a lot here too. Okay, we're not going to give you much longer. Last two questions, I promise, and then we're going to let you go. I hope we haven't, it's not too much, right?
It's been fantastic. Thank you, guys.
So Augustine.
Yeah, thank you very much for this amazing talk. I like the way you center the patient in your decision-making process. A lot of questions have been already done. I was just wondering regarding the ischemia trial. Of course, it was like a big bang in that field. How does trial change your practice or not on a daily basis?
Yeah, great question. So I think ischemia for me has just made me take my time. I just don't think we have to rush. That's where I think it's changed things for me. It hasn't meant I don't stent stable patients. I mean, none of these trials have directed me to there. But for some patients, you know, I just have this conversation with them and I see what they want to do. Importantly, I very rarely now, and in the UK, actually, the practice is really changing away from angiogram query proceeds and much more to, if you want to make a diagnosis using an angiogram, fine, but then you stop and think, you up titrate medical therapy, you do lots of other things. Because I don't know how it is for you guys in the US, but often for me, the pathway to the cath lab table is really messy. Sometimes they've not even seen a doctor, they've just seen nurses in a chest pain clinic. And so I don't feel comfortable with a patient on a cath lab table having a conversation about their symptoms. And ischemia trial has made me feel I can take them off the table. I can think about them for a bit longer and then I can decide what to do. Obviously, we don't have really long-term data from ischemia, but there's a signal for safety, at least within that sort of short to medium term. So we've got time, basically. And that's mainly, I think, where it's educated me.
Excellent. Last two questions, one from Pier Pasquale and then Nikos.
Yeah, really enjoyed the talk and the discussion. Thank you. So my question gets back to the placebo effect. We've seen, like, back in the days when anti-anginals were introduced and all that, most of the times was very little background therapy, and oftentimes drugs were stopped before starting new therapies, and actually the real effect of the therapy was seen. And now the more we get into, into the future kind of thing, we have a lot of therapies. And also what we've seen with Orbita-1 is that we have added on top of 12 months of anti-anginal therapy, Revasc. So my question is, now also gets back to the design of Orbita-2. What are your expectations when you're actually going to test kind of Revasc without a strong background of medical therapy, and also referring to placebo effect? So in Orbita-2, you're gonna assess symptoms on a daily basis with a smart app kind of thing. So how do you think that translates also when you compare patients going to the office and actually filling out questionnaires? So I guess it's very subjective. So oftentimes patients, when they're enrolled in trials, they're enrolled, so they kind of want to show the investigators that something is happening, right? So do you think also the mode of attribution of assessment, so doing that on their own at home, is going to change what we see? Thank you.
Yeah, two fantastic questions. So the first one about kind of being off anti-anginal therapies. So Orbita-2 will, I guarantee now, be criticised by the general cardiologist for the fact that they're off anti-anginals. They'll say, well, that's not guideline directed. But the reason we did it that way is because I felt that really the model was the renal denervation data. And if you want to work out how much a therapy is effective, it's got to be just, what does the therapy do? And importantly, to come back to Azim's point, we are terrible at getting patients onto 2 or 3 anti-anginals. So in the real world, very few patients are on the amount of medical therapy that they were in Orbita-1. So what I'm hopeful is you'll have 2 trials and you'll go, here's the efficacy if a patient wants to take drugs, and here's the efficacy if they don't, right? And you can have a conversation with them, because actually we've shown that revascularization isn't really there for prognosis. Doesn't mean it needs to go away. We just all need to have a conversation with our patients about what they want. And what's wrong with that? That's okay, isn't it? You might prefer to have physio than have a knee replacement. You'll have both options, right? And so, but watch the space. I'm sure there'll be lots of people who criticize it being off anti-anginals, and we as interventionists will have to say, well, lots of patients don't want to take those drugs, and here's the efficacy. Now, if it doesn't work off anti-anginals, that's a whole other conversation. We'll have that later. And
so basically, you should be looking for, like, to improve your skills, maybe exactly. Do other things as well.
Exactly. Luckily, there's lots of acute patients to treat, right? And there's it's a shame I didn't train in structural. And then your second point about symptom app is a really good point. So the reason we introduced the symptom app is because the questionnaires are said to be well validated, etc. But in fact, the questionnaires were all validated against daily angina frequency, because ultimately, if you validate any test, you want to validate it against the thing you care about. And so obviously an exercise test is miles away from daily angina frequency. Questionnaires are quite far away. When something's far away from the thing you care about, you have to test how closely related they are. You're right. There's always in a trial this kind of Hawthorne effect. If I'm in the trial, I need to tell my doctors what's happening, et cetera, and ultimately, I think that's why the placebo arm is important, right? Not knowing what you've had done, hopefully means that effect of being in the trial is spread across both arms, and we see what happens. What I'd like to see from the app, and this is actually already happening, hopefully, is we're going to introduce it into lots of other trials, not just Orbita, trials outside of our group. And what would be fab is if one day we can say, have this open access app. It's so easy, or copy it, do whatever you want to do. And if you have this particular symptom, so you see someone in clinic, they say, I've got chest pain. You say, okay, great. I'm going to make a diagnosis. I'm going to give you some risk prevention. In the meantime, score your symptoms. And in a month's time, when I see you, if your score is in a certain range, PCI might be useful for you. If your score isn't in that range, it might not. But we'll see. And you are right. Like I at this point don't know any, but I can only assume that asking a patient if they had pain is as good as it gets to being you know, the reality of symptom collection, basically.
Absolutely. Okay, Nikos, last question. And then we have to let
I'll
Russia
try
go.
to make it fast. So thank you very much. I'm looking forward to all the data that are going to come out the next years. My question is, especially because we have a trouble sometimes linking the physiology with the underlying biology and the ischemia burden with what tests we have available right now. Do you envision any role of biomarkers in the pathway of decision making? Other biomarkers collected peripherally or biomarkers collected, for example, when you do those balloon inflations that you mentioned in the cath lab, and maybe pair those biomarkers with the readout to improve your prognosis. And I'm not necessarily talking about existing biomarkers. There may be new biomarkers that they're coming out, and they're better for stable coronary disease, contrary to the ones that we have now that are better for acute coronary disease.
Yeah, so I mean, I have to say, Azim, I'm going to say your team asked the best questions. So these are, so that's exactly, so in fact, long story, but we are currently trying to get some funding actually for a subset within Orbita-2 to do exactly that, where we actually do coronary sinus sampling and try and work out if there are particular markers of ischemia or particular kind of novel new biomarkers. We're working with a group in Edinburgh that might predict, you know, risk or benefit of treatment. In reality, that's not going to, you know, it's not going to be powered enough to give us lots and lots of data. I think there's going to be much more. Obviously, we know that whether it's troponin or BNP or, you know, all of these markers are far too broad to really be useful. But wouldn't it be brilliant if there was something out there that could let us work out which patients to treat? Yes, it's not so much, as you know, a sort of focus of my research, but I think there are lots of groups looking into it.
Thank you.
Thank you.
Nikos has a particular interest in biomarkers, and he's done some basic science research in that. So hopefully he's gonna
find the answer.
He's gonna help us figure that out. Russia, thank you so much. What a great morning. Great discussion. The fellows, I got to tell you, the fellows amaze me because they really ask such great questions, and I think it shows us our field is in great hands. But really, thank you. That was superb, great discussion. We really loved it, and we love having you on Monty Hart.
Thank you so much for having me.
Okay.
Thank you all.
Take care.
Bye,
Thank you, everybody, for joining. Okay.
Bye.
Bye-bye.